Good morning.
Yes.
Good morning, sir. It's very happy that we're very happy that you can join us with your live case. We have a very senior and very learned panel that I will forego the introductions of now, just in the interests of time, and ask you to introduce your case so we can see what you have in front.
Sure. So good morning to all of you. In fact, when I was assigned a live case, I asked Vishal specifically, can we do it on Saturday? So thanks the organizers that they kept us working on the Sunday. Whole team is here. I'm Dr. Rajneesh Kapoor, and with me Dr. Sushil, Dr. Himanshu, Dr. Shashikant, Shubham, Vikram, all the technical staff. So everybody is here on Sunday, and in fact, there were two live cases from Medanta. So Dr. Chandra decided that he will do a case in a box. Next time I'll also ask for this option.
Well, thank
Okay.
you for allowing us to enjoy this case with you.
Yeah. So this is the case. Can we have a slide of the introductory slides? Yeah. So 79-year-old hypertensive patient, presented with chest heaviness, shortness of breath. For last 1 week only, he was doing fine up till that time, and last 1 week he had lot of symptoms: rest angina, unstable angina, few episodes, and that's where he got himself investigated. He was investigated somewhere outside hospital, and echo was done. It was fine, but then symptoms were very typical, so he was angiogrammed outside, which showed a critical left main disease. So can we run the first shot? Okay, so this is the first shot. This is today's angio, but he had an angio outside which showed the similar picture. So left main tight and extending into both the ostia of LAD and circ. So look at this. Yeah. So Medina 111 and calcified. The previous history is patient had a stent in LAD, which is not coming up till the ostia. There is a gap. And see this. So calcified, both arteries, left main critical, extending into both the ostia. So this is the picture, and obviously, stop. Obviously, as a first thing which came to our mind, that we kept the patient and discussed with the heart team for bypass surgery. So he was admitted for bypass surgery, but then heart team decision, he was found to be having a cirrhosis liver. So that's where he was, denied for surgery, and then we came into picture. So now alternative plan is to do the stenting. So I'll stop it here, and we can discuss with the panel and then move ahead.
Dr. Kaul, would you like to have a word?
Hi, Rajneesh. This is Dr. Kaul. No, I think
Hi, Doctor.
a good thing is that the landing zones in both the LAD and the circumflex seem to be quite good. So I think one can do a crossover, go with one, cross it, put in the other stent, do a pot, and then see what you hear. I think that would be a reasonable strategy.
Dr. Mishra?
Dr. Mishra, Sandeep Mishra. Hi, Rajneesh.
Hi.
I think for me, I'm concerned about the calcium part. So what do you plan to do about it? Because it looks like there is some calcium, and I think probably you'll do IVS or something to better define it and then take a call on it.
Right.
Anybody from panel?
So, sir, as you can see, trifurcating left main. So, ramus is not a big size vessel. So, most likely DCB for ramus. Circumflex, you have to decide whether you want to go for a two-stent strategy or a provisional strategy, and think of the circumflex as a second option, whether doing DCB to circumflex or a tap, because a 90-degree bend. But for a trifurcating left main, if I am doing a DCB for ramus, I would go for a decay crust stenting. That will be better for me.
Dr. Kapoor?
Right.
Right. I'm affected by the case in a box that Dr. Mani presented as part of the left main session, where there was this horrible angiographic 80% ostial but short stenosis in the circ that was isolating a large OM in the setting of a trifurcation, where when they did the physiology on that circ, it was negative over and over and over again, and then he showed 18 months to 2 years follow-up of where that patient's done well. And clearly there is tight disease in the ostial LAD, clearly extends to the left main. I kind of wonder about the circ. And so is there an option to sort of do a cut DCB of the circ if you think that there's disease, do a provisional from the left main into the LAD and then rescue the circ with either a culotte or a reverse crush when you're done.
Yeah.
In case you,
So-
or a mini culotte, in case you don't need to, stent the circ, for the reason that you have a true trifurcation there.
Yeah. So I think very valid points. And in fact, we have considered and discussed all these points while planning this case. So should we go ahead how we progressed?
Yes, definitely, please.
Okay. So one, I think, yes, we thought that Ramus is there. It's kind of a trifurcation initially, but then Ramus is not very big. And then on a careful analysis, next one. Okay, this is next. No, sorry. Come back. Eliocaudal, come back. Yeah. So if we look at this, I mean, we did imaging up till now. We'll show everything to you, but actually that ramus ostium looks good. It's not diseased, and it's not ramus. It's just a millimeter away from the LAD origin. So it is a very high diagonal on OCT. We checked it very carefully. And then obviously, as Sandeep also pointed that, but what about the calcium? So we are coming to our strategy. I feel, as Sanjog is discussing the case discussed a few days back, that was an isolated circumflex ostium. So this, in any case, is a very critical left main. We have to stent crossover from left main to LAD. And there is a high chance that we will make it very complex if we start losing the circ. So we are planning a upfront two stent strategy, one in the circ and then a crossover left main to LAD. So let's move ahead and show you the imaging. Next. So we wired both the vessels. Next. So 2.5 millimeter balloon, a normal balloon, we dilated both the ostia first. Next. And there is a lesion in the mid circ also. That also we dilated, and it's quite a calcified lesion. We found it little difficulty in advancing the balloon there. Next. Okay, so then we took a cutting balloon. So this is a cutting balloon, 3 millimeter at both the ostia. We cut the ostia with a cutting balloon. And in fact, it's not only the circ ostia. There is a disease ahead also. We'll show you the imaging part. Next. Can you come view one view prior? One. Okay. Next. Yeah. So this is a cutting in both the ostia. Next. And this is we did the OCT on both the vessels. Please show the LAD coming back to left main first. This is LAD. There is a stent in LAD which looks reasonably okay. So this is LAD coming back.
Dr. Kapoor,
And
we are
look at
not
the
seeing your
calcium.
OCT images.
Yeah, OCT, please.
Vibhuti
Please show
here.
OCT here. Please show OCT on the screen. OCT on the screen, please. Okay.
Yeah.
Make it larger. Make the OCT image larger. Yeah. So come back. So there is a stent in LAD. We're coming back from LAD to left main, and start looking at the calcium arc now. So 320 degrees, 0.8 thickness. So this is Ultreon 30 OCT. It's giving us automatic figures. And this is the ostium. Look, highly diseased and lot of calcium. Come back. This is a distal left main, very tight. And now we are entering to the spacious left main. Yeah. So run the other OCT from circumflex to left main. Even circumflex is highly calcified. Come back. So look at the calcium here. This is a circ disease. This is still, we are away from the ostia. Look, come back. Keep coming back. So this is the ostia of the circ, 2.2, come back, 1.5, 0.7. Tight, very tight here. Come back. And this is the distal left main. Okay. So these are the images. And clearly, I think circumflex ostium is very critically diseased. And provisional, I'm little skeptical keeping it provisional. So upfront, we are going ahead with 2 stent. Regarding the ramus, yes, we thought of it, but then in one of the views in OCT, there is a small gap. It's not exactly a trifurcation. It is arising from the LED 1 millimeter, 2 millimeter ahead of the LED origin. Okay. So this is the thing. Next. So then now at this time we decided that there is a lot of calcium. Let's do a IVL. So we are doing a calcium modification by IVL. This is a 3 millimeter into 12 IVL balloon. We gave almost 50 pulses into the circ. Next. Next. And then at the ostium, coming to the LED left main, and then into the LED left main, 50 pulses. At this time, while giving the IVL inflations, patient had some hypotension on mild inotropes. So that's where I was saying we're waiting a lot. So at this point, once patient had hypertension, we thought let's fix this with a stent first, but then now it's okay. Next. So this is a post IVL calcium modification. And now after this, we stented the middle part of the circumflex. Next. So this is one Onyx 2.512. Next. Okay, so we are all set for the bifurcation stenting. I think we can take the inputs from the panel and discussion while we continue the steps.
Yeah, Rajneesh, one quick question. So how do you choose the size of IVL balloon? So you have LED and left main. So which one do you choose? Because for IVL, the sizing is the most important.
Yes, I agree. So we did the OCT prior to the IVL. We were fortunate that both vessels were almost 3 millimeter caliber. LED was 3.4, circumflex was 3. So we took a 3 millimeter IVL balloon sizing.
Yeah, basically there's not much calcium in left main. So the size should be taken according to the distal vessel. If
Yes,
left
yes.
main had calcium, then you have to choose according to left
second.
main. Yeah.
So we are planning almost a nano crush here, and then followed by pot and kissing balloon. So this is 3 into 18 at the circ ostium. Usually nano crush steps are that we keep a balloon in the main vessel, but we are not doing that since we'll be occluding the left main. So yes, visually it will be very mild protrusion. That's what we are planning. And then crush and then followed by kissing balloon to keep it simple.
Dr. Rajneesh, Dr. Omar this side. Good morning.
Hi, Omar. Hi, morning.
What do you think about mini clot in this case?
See, I think this is the best way we give the good patent ostium here. If we see, just mag the view. So if we are very, very careful and meticulous here and keep the protrusion very small, I think that that way we are more comfortable.
Okay, thank you.
I think Dr. Kapoor, the main stress Dr. Umar is asking is what will be your strategy? You do not miss the circostium also in this case.
We want.
Yeah, but that's very important, you know.
Yeah, we want. So we'll be very judicious with this.
Yeah, because
Placement of stent.
I think you're taking a little chance by, you know, keeping it there, you know. Missing the ostium is common, and when the two things are well apart.
I think it is the choice of the person who's doing
Obviously.
operator. So it is his comfort level, whatever he's more comfortable with. But
No,
ideally, culotte would be a very ideal in this case, looking at, yeah.
What are your choices of the stent?
yeah, Onyx. Radial strength, side branch access later on once we do the kissing, everything.
Any preference for marker-based stent on the side branch? Dr. Vibhuti here, sir.
Just give me a minute. Let me just do the osteal stenting, and I come back and answer these. Check.
It's not a case in box.
Hmm? Check. So we do spend a lot of time to make sure that there is not a miss at the ostium, and keep it minimal crushing also. Yeah, go up on the circ ostium, circ stent. 6, 7, 8. Check. Okay. 10, 12. Down. So these few maneuvers we do while we inflate the stent, we check again, and initially we take some time to place. There is angulation, you know. So I'm taking the balloon little back and inflate it again on high pressures. Go up. 6, 8, 10, 14, 16. Down. Okay. It is almost like a mini crush, but only little changes that we keep the protrusion very minimal. Yeah. So this is the circ stenting done. It looks okay. If we need to dilate down, huh? Give me a 3 millimeter non-compliant balloon. Okay. So sorry. Coming back to discussion, what was the point?
Yeah, Dr. Rajneesh, is there any specific advantage of nano crash? Because everybody has, and you also know that in nano crash there is always a chance of missing the ostium. So, do we have evidence that nano crash restenosis is less, or why this technique?
So if now only point which makes this technique, in discussion for a debate is that we miss the ostium or not. So in case if we are absolutely making it clear that we are not missing the ostium, I think this is very good, because
How can we do that?
we'll show you in the imaging. Only thing is, just being very particular and methodical while placing the stent in various views. We get a magnified view. I mean, everybody of us is doing that, but just spending more time and being more methodical. That's it. Okay. Check. Little check. Okay, by post dilating it inside, since then I'll be taking out the wire. Go up. 16, 18, 20 down. 18, 20 down. बस सर, बस थोड़ा देर रुक जाइए. Okay, check. Check. Okay, keep it here. Okay. So now I have done post dilatation. I'm taking out the circ wire, and we are on to the left main to LED crossover. There is a stent in LED. We'll overlapping with that. Check. This looks okay. Okay, another view. RA caudal. थोड़ा और पीछे आ सकते हैं. मैग हटा दो. बस सर, बस 5 मिनट और दे दीजिए हमें. ओके, ये ठीक है. हाँ हाँ. Okay, go up on the left main stent. 6, 6, 7, 8, 10. Down. So this was 3.5 left main to LED, and we picked the size again, the OCT. Although visually it looked 3, but OCT showed us that it's 3.4 vessel, and there is a stent. So we are overlapping with that. We have taken a 3.5 for this crossover and dilated to a little lower
Rajneesh,
pressure.
we'll just come back to you. We go to Praveen, who is waiting, and then you show us. Keep it recorded.
Sure.
Yeah.
Sure. Done. Thank you. Yeah. Okay. Hi. So we have done our next steps, and we'll show what we have done. Come back. So stenting, we showed while we placed the stent at the circ ostium and then crossover 3.5 18 onyx from left main to LED. And okay, next, 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 next. What आ गया? हाँ, okay, okay, next, next, next. पीछे नहीं आओ, next. So one thing I wanted to tell that once we are doing the osteal LED, osteal circ, the ramus, it was not exactly a trifurcation, so we were slightly away from that, and that's the reason finally our ramus or high diagonal is doing absolutely fine. So this is a crossover from 3.5 from left main to LED with 3.518. Next 22, sorry, next, next, next. So after this we did a pot. This is 4 mm balloon. Pot done at almost 18 atmospheres, and then we recrossed the wire. Next, next, yeah. So wire recrossed, and then 2 mm initially to open the struts in the circ, and 3.5 we kept the balloon in the left main LED. So next, we stepped up the balloon in the circ ostium to 3 mm after this. Next, next. This is a 3 mm balloon at the circ ostium and 3.5 in the left main LED, and we did kissing at good pressures. Next. Yeah, this is how it looks, but then we are showing the imaging. So as the concerns were there that we should not miss, so this is a OCT from circumflex to left main, intraluminal. So this is a circ and wire is going into LED. So look at this. So this is absolutely well covered, and in fact on the stent boost we can find out that there was a minimal crush, and which we have now done a adequate kissing. This is the circ ostium starting, and now we are showing you a OCT from LED backwards into the left main. So as a final step, we are almost done with everything. Any points, any inputs?
No, I think finally it was very well done. The concern of many of us was that there is always a small risk of missing the ostium of circumflex. That's why mini culotte and other techniques where you're absolutely sure that the circumflex ostium is very well covered. If it is, finally, if you find out that there's a small gap, then you are in a trouble, and then what to do, whether to put in one more stent
Yeah,
there.
I think it's pretty valid, but all things depend again on many factors. The angulation was very good here, almost 80-degree angulation. So that was one point that we decided with this. And the only little change we do that keep taking multiple shots, various projections, so that we find out that it's only a minimal protrusion. If it is LED diagonal and we have to do nanocrush, they say that we keep a balloon in the main vessel, pull back the stent from the side branch. When it gives a resistance, we inflate the balloon. So that justifies a minimal protrusion. But here, that was because of hypotension and everything, we didn't do that step. So this is OCT from left, come back. Yeah, come back from here. So good MSA is achieved. Come back. Please come back. Keep coming back. 5.8, 5.9 in LED, 6.7 here. Small part of LED ostium we dilated with 4 also, 6.7, 7.6. So this is, yeah, look at this. Come back. Yeah, so this is the circ ostium. Okay, come back. Now we are entering the left main. This is the left main fully opposed.
Not exactly.
Yeah. So final pot we are doing with 4, and that's it.
Yeah, very convincingly that the ostium is well covered. Yeah.
Yeah. So angle matters, and everything is decided. And then if we also, very importantly, we have to do a bed preparation in a good manner. We did IVL, we did cutting balloon both to expand the ostiums. That also helps, in not only in good placement, but later on with a good kissing. So Yeah.
Dr. Kapoor, what was the index size of the LED and the left main on OCT?
Yeah, can you show Anjali? So LED was 3.3 to 3.4. The previous stent expansion, so that was the distal where we wanted to place the distal end of the stent. It was 3.3, 3.4. That's the reason we took 3.5. And left main was 4. Show me the left main size.
So the biggest challenge, the nano crush you did with the stent, or you used another balloon?
No, we did with the stent because we didn't want to occlude the left main and do that. Patient had some hypertension, so we did with the stent only.
Okay.
Sir, one query. 3
Stent
stent
was-
in circumflex, 3.5 in LED. According to Finnett's law, why not a 4.5 pot? And secondly, in the circ ostia, in OCT, I thought the area was
Are
4.7, which is quite less for a 3 stent.
Circ ostium ka dikhana. Okay, give me a stent boost here. Okay, go up here. 6, 8, 10, 12, 16, 18, 20, 22 down. Left main size first. First give me that answer. What was the left main size pre?
Can you show the OCT image on the pen?
Yeah, so left main size was 4.2.
Okay.
And now show the OCT from circumflex to left main.
So the
And ostium
intraluminal
of,
size was 4.2.
yeah. So we have almost done 4.3 with this dilatation. 4. Okay. Final picture.
Can you come to
Take
the
up.
circ ostium post? What was the size?
Yeah. No, not pre, after the stent. Yeah. So this part, this is the circ ostium, 6.8.
Good.
This is circ or LED? Circ. So 5.8.
That's good.
Good.
Yeah. Okay, final shot. So we are showing you the final angiographic shot. Yeah, look, the ramus or high diagonal is absolutely fine because we figured out that nothing would happen to that. And the both ostiums look pretty expanded, well opposed. We have done a final pot. We have made the left main 4.3. We have gone with 4 millimeter up till 22 atmospheres. So I think this is are pretty reasonable from here. And any final comments, we are absolutely ready to take that. Any discussion points?
No, I think we went through the case along with you and discussed it out throughout your, procedure. If there's any point, Dr. Mohan or Dr. Omar wants to
I
make
just
here.
wanted to tell you what is the definition of a ramus intermedius. A ramus artery is one which arises within 6 millimeter of the bifurcation. So whether it arises from LED or the true bifurcation or
Doesn't
from the
matter.
within 6 millimeter ostium LCA, it's called ramus.
That's fine. So I think by definition it still may be ramus. I am trying to say this, that because there was some gap, so chances of occlusion after this bifurcation stenting was much there. I mean, still we were contemplating that we may lose that ramus. I mean, during the process, our heart rate was high. That still there may be a chance that we may have slow flow in the ramus or may lose it. But because ostium was good and it was slightly away from the LED ostium, so chances were that it may remain patent, and that is the scenario.
So did you
Yeah,
think
it's
of putting a wire in ramus at any step, any stage?
I thought of that initially, but once we checked on OCT, that ostium of ramus was good, and it's not exactly at the. See, my anticipation was that if it is absolutely right, a true trifurcation, I mean, arising from all three vessels arising from the same point, then since we are doing a crush there, that crushed part may be coming over the ramus, and it will be very difficult to save it. So once we found out that that is not the scenario, then we figured out that it may remain patent.
Rajneesh, can you show a caudal view?
Yeah, iliocaudal, please. More caudal, maximum caudal. Yeah, okay, keep it here.
Yeah, it looks fine, you know.
Yeah, there is some pinching, I mean, that is expected, but see, now it is very clear what I was trying to say. It is
Yeah.
not exactly coming from the
Yeah,
same
it's
point.
not
It is
actually coming from the middle, it's coming from the upper branch, the LED.
yes, 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 yes.
Okay.
So, yeah, thank you very much for a nice discussion, and there were many valid points in the discussion which were very productive. And obviously, once we're doing such interventions, there was a calcium. We need to take care of a good bed preparation, and once we do that, I think a good technique where any operator may be friendly with or comfortable with, we can go ahead with that. So it looks pretty good. Yeah.
Thank you and congratulations the whole team for
Thank you.
showing a complex case superbly done. So thank you from all of us.
Thank you. Thank you very much.
Thank you, Rajneesh. Very good demonstration.